So what we're going to talk about today, actually, is tele-emergency medicine, how you can live in New York but see patients all over the world. So we're going to start with a story. The first two stories. The first story is about an emergency medicine doctor. This doctor met her husband in medical school. Okay, she was a couple of years ahead of him. And when he graduated from medical school, he had a commitment to the Army. And the Army hospital he was stationed in was in Japan. So at his graduation, she had to make a choice. Either she could go with him to Japan, live with him as a wife, stop practicing medicine, or stay stateside, tongue twister, leave him for 2 to 3 years, and actually continue to practice medicine. So what's a girl to do, right? Well, actually, what she did was she went to Japan, she stopped practicing medicine, she had a baby, she got an advanced degree, and every day her husband went off to work and she stayed home. And she says that even though she was productive during those 2 years, she resented every day he went to work because she was a doctor too, and she couldn't practice medicine. 8 years later, they're back home, they have 2 kids, she's an academic physician, and their marriage has survived no worse for the wear. The second story is about an elderly man. He has metastatic prostate cancer. He lives in a skilled nursing facility. 4 times over the past year, he has gone to the hospital for tachycardia, tachypnea, or intractable pain. And he has a 100% admission rate to the hospital. Every time he was in the hospital, he got treated for a UTI or a pneumonia, and he got sedated for delirium or agitation every single time. Came back to the nursing home on antibiotics, worse for the wear, and slightly deconditioned. So, how are these people connected? Well, what if the emergency doctor in Japan could see and evaluate the patient in the nursing home in America? What if she could see if his tachycardia, tachypnea, and intractable pain were treated outside of the hospital? And what if she could do that while having her baby, while living with her husband, and even getting her advanced degree? How would that be possible? Well, it's possible because of telemedicine. So, telemedicine companies have been around for about 40 years. Most companies feature direct-to-consumer or clinician-to-clinician interface via an audio or a video modality. Telemedicine companies are as varied as the customers they treat, with one quote saying there's 450 telemedicine companies servicing 1 million different customers. For EM doctors, telemedicine opportunities come in basically 3 different varieties. There's either tele-urgent care, tele-emergency consult, or tele-emergency care. So tele-urgent care is usually direct-to-consumer, right? We've seen this, right? Teledoc, Doctors on Demand. You've probably seen their ads on the subway, okay? The money that's going into these companies and coming through them is enormous, okay? Doctors on Demand went through 2 rounds of funding 3 years ago for its Series A and Series B, and they raised $75 million in funding in those 2 rounds, okay? There's a lot of money in coughs and colds, aches and sprains, where you can get to the doctor directly. However, there's also overprescription, under-testing, high patient satisfaction, but there's still a confusion about physician satisfaction in practicing this kind of medicine. Now, as EM providers, tele-urgent care, while certainly profitable and related to emergency medicine, is probably unlikely to satisfy all of your needs. Here you are in New York City in some of the best residencies we have to offer, and you're probably not ready to sit down waiting for the ding of an iPad for somebody who's traveling to be like, oh, I have a cough, and they want some antibiotics. So we're going to move on. The next thing we're going to talk about is tele-emergency consult and then tele-emergency care. So tele-emergency consult services are similar to tele-stroke and tele-ICU, right? So we know that hospital systems, especially ones with rural emergency departments, may have departments with less than 10,000 annual visits and no actual emergency medicine trained providers in their proximity, right? So what do when they need to figure out if a patient needs to be transferred or get a higher level of testing, right? They actually go in front of a computer, they find a consult, another physician, usually the same system, who can either order tests or make recommendations under the same EMR, and then decide the person needs to be transferred. States like Arkansas, Maine have huge networks like this, okay? So that any one of you guys that's going to work in emergency medicine over the next 20 to 30 years,